Hello and welcome to Acupuncture Professional. We're here today to talk about safely using acupuncture in the final stages of pregnancy, and this is presented by Sarah Budd. Today's webinar is part 3 of a 3-part series looking at acupuncture in pregnancy. We've already talked about safely treating conditions in the first trimester of pregnancy and safely treating conditions in the later stages of pregnancy. So today's webinar is looking at those final stages and using acupressure, what you can teach your patients. It's now with great pleasure I introduce to you Sarah Budd. Sarah Budd is a nurse, midwife and trained acupuncturist. Sarah set up an acupuncture service in Plymouth Maternity Unit in 1988 after completing a degree in complementary health studies at Exeter University. In 1991, Sarah was awarded the prestigious Churchill Fellowship Award to study acupuncture anaesthesia in China. Sarah was appointed the UK's first full-time acupuncturist midwife funded by the Public National Health Service, the NHS, in Plymouth in the UK. And it's with great pleasure I hand over to Sarah Budd.
Thank you, Kath, for that lovely introduction. And hello, everybody. As Kath said, this is the third webinar talking about the final stages of pregnancy and using acupuncture. And we're talking about acupuncture in the final stages of pregnancy, encouraging labour and using acupressure during labour, what you can teach your patients. So as Kath said, my background is in midwifery, and I trained in traditional Chinese medicine in London and in China, qualifying in 1988. And so my webinar today is based on my experience of using acupuncture in pregnancy for 24 years in the National Health Service, which gave me access to a large number of women, and followed on to 2 very special colleagues joining me to run the service. Sadly, our service closed in November 2012 due to funding changes and so-called lack of evidence, despite us having data on 8,000 patients. So initially, I trained as an acupuncturist because I demonstrated that I didn't have more choice to give women of pain relief in labour a chance to get away from just the pharmaceutical options. As I said, this was the mid-80s when I was training, and the first transcutaneous nerve stimulation, or TENS machines, were just beginning to appear. So there really wasn't much choice around at all, other than gas and air, pethidine, or strong pain-relieving injections. They've changed it now, and epidurals. So my first years of experience were really focused on being with women in labour as their acupuncturist and midwife. And this was, to me, an absolutely fantastic privilege and most rewarding. And I was delighted by the results. And in a position to be able to stay with women throughout their labour. This moved on to more experience of treating antenatal conditions. But as I say, my first experience was really in using acupuncture during labour. So we'll talk about that today. Other things we're going to talk about, well, we've talked about this in the previous webinars, but I just do need to come back to what's different about treating pregnant women in terms of room layout, because you will see these patients possibly for around 36, 37 weeks. So just a few little tips there for those of you who are just starting on the road to treating pregnant women. The importance of preparing for labour, especially now women are working so late in pregnancy. This is the chance to start really focusing on what's happening. Chance to really think about the imminent arrival of this special little person and the end of a long 9 months. So to me, we're starting to really focus in on this around 36, 37 weeks. What can we do to help encourage labour, so-called induction? How can we use acupuncture in labour and acupressure? And what can we teach patients and birthing partners? We'll dip into the research that's available and also talk about some resources. Forgive me if you've heard this before, but just to quickly go through the treatment room, a little tip about never treating pregnant women lying flat. They will get postural hypertension, particularly at this stage of the pregnancy. They've got all the weight of the baby lying on their inferior vena cava when you lie them flat, and their blood pressure will drop very quickly. They'll feel sick, nauseous, sweaty, and will go very dizzy and unconscious if you leave them in that position. Easily remedied, treat them sitting up, or lie them on their side. Ventilation, pregnant women tend to be hot, particularly if you're treating in the summer months. Make sure you've got good ventilation in the room because of this tendency to fainting. I personally don't like treating pregnant women sitting up in a chair, again at this later stage, but that's up to you. You may have a patient who's had hyperemesis. Just to have a bowl handy, they could still be vomiting even at the end of their pregnancy. I recommend not leaving patients alone at this stage because of this tendency to get hot and fainting. Focus on the problem, use few needles, and take care with your technique. This isn't so important as earlier in pregnancy because if we're thinking about getting labour going, we can actually get a bit more stronger needle technique going. And frequency of treatments. Well, if somebody's coming to see you for induction of labour, and they have a date from the hospital to go in and have a medical induction, you're not going to be giving them weekly appointments because you just won't have the chance to get very far. So you need to think about what's ideal and what's practical. And of course, if they've got other children at home, it may be ideal to ask them to come for daily treatment or every other day, but this may not be so practical for them in terms of other childcare or whatever. A few little red flags to mention. Well, as I said, some women do still have hyperemesis even the whole way through the pregnancy. So if a patient does come to see you, you've never met her before, she wants you to try and help her get prepared for labour or induce her labour. If she has been vomiting and she's unwell and it hasn't been addressed, just to make sure that somebody medically assesses her. Vaginal bleeding, this isn't normal even at this stage of pregnancy. Some women do have a show with a little bit of blood in it, and this is actually quite normal. It just shows that the cervix is beginning to stretch. But fresh vaginal bleeding, bright red blood on its own is not normal and should be referred to the midwife or GP. Abdominal pain, well, this stage of pregnancy could well be contractions, so the main thing there is to see if this pain is coming and going. If it's a constant, quite strong abdominal pain with no break, no break in the tightness of the abdomen, then it could be a sign that there's a problem with the placenta. So it does need referring back to the GP or midwife. Fluid leakage, well, her membranes may have gone. That's fine. It's just to be aware of it as long as she's over 37 weeks. Generally feeling unwell. This just might be a sign that there's some kind of possibly urinary tract infection going on. Urinary tract infection in pregnancy doesn't always have the usual symptoms we associate with it, but it is important that it is picked up on because it can turn into an ascending infection that affects the kidneys and can make the woman very poorly. I've put here tightenings before 37 weeks, just in case you're seeing these girls a bit earlier. 36 weeks, well, the baby's pretty mature, but they can still have breathing problems between 36 and 37 weeks. So it is still classed as a premature labour. And I would suggest that it's a good idea just to get some medical input, discuss it with her midwife, just to see if there's anything that you should be aware of if she's not yet 37 weeks. Itching, especially the hands and feet, we talked about this in a previous webinar, may be a sign of a condition called cholestasis, which is excess bile salts under the skin, and it does have a raised incidence of stillbirth. So again, if your patient is coming to see you for the first time and nobody has been dealing with this or done any type of diagnosis, it's very important that they go and have a blood test. Headache with visual disturbance and epigastric pain may be signs of preeclampsia, and preeclampsia can accelerate to a very serious condition of fitting with eclampsia and does need urgent medical attention, and it is more likely at the end of the pregnancy. So that's the scary bit over with. What do we know about the history of acupuncture? Well, in the ancient texts, I've taken from the Zhubing Yuanhou Lun from the year 610 CE in the Sui dynasty. In the 9th month of pregnancy, the fetus begins to receive the essences of stone to form the skin and body hair. the 6 fu and 100 joints. All is complete. The woman drinks tasty drinks and eats sweet things. She loosens her belt and waits. I think that's wonderful. This is taken from Pregnancy and Gestation by Elizabeth Rochelle, published by Monkey Press. They also talk about the 10th month, and of course pregnancy is 40 weeks, so we tend to think of it as 9 months, but it's all a little bit complicated. They say in the 10th month of pregnancy, the 5 Zhang are perfectly formed, the 6 Fu all communicate, the Qi of heaven and earth are introduced into the cinnabar field, and the Chinese character for cinnabar field is Dan Tian, which we may be more familiar with as a term in the lower jiao, which means that the articulations and relays and the spirits of man are all complete. There's a lot of emphasis in the texts on the mother knowing the phases of development of the embryo and fetus, and therefore how to prevent problems for the fetus and herself during pregnancy and delivery and afterwards. And it's a really lovely way of looking at the whole of gestation. If you're interested, I can recommend this book for further reading and other work by people like Sabine Wilms, who've done a lot of compensating Sun Tzu Miao's work on pregnancy. Labour is said to commence when the yang activity replaces yin material growth. The qi flows freely and moves blood, and the door of the uterus opens. So where does it all begin? Well, I believe very strongly that we can do a lot more to give patients and their partners and their birthing partners the tools to prepare for labour themselves. You may have been treating your patient during the pregnancy or indeed for a long time beforehand, particularly if it's an IVF pregnancy and you have a strong relationship with her. And you may be very familiar with her constitution, state of her qi and blood, etc. Or you may be meeting her for the first time. It doesn't really matter. But I really recommend you arrange an appointment for around 37 weeks to teach acupressure as preparation for labour. This can also then be used for pain relief when labour starts, which we'll be also discussing later on. So there's going to be a little bit of overlap here on acupressure. Thanks to our colleague Deborah Betts in New Zealand, it's possible to download and print a booklet on acupressure for labour, and I encourage patients to do this for themselves. There's also a DVD and now an iPhone app which are available, and these are fantastic resources for couples. This shows you the DVD and the app. I'll come back to that slide in a minute. So this can be taught from 37 weeks. You can do it in a half-hour session. You can do it in groups. I used to get 2 or 3 sets of couples in together, which saves time, and actually it's quite nice interaction. It's very discreet. We can teach the points on different groups of women with other husbands around without it being any problem. And I think it's actually quite important to demonstrate the actual pressure. My little trick is to ask usually the guy, for his forearm, and I choose a random area, maybe around triple burner 5 or 6, to demonstrate the pressure by, first of all, pressing in a kind of pleasant, more like a stabbing kind of way, and then I demonstrate it again as if my thumb is sinking into butter. So that idea about slowly going in and making a connection with the actual acupuncture point, and they can very clearly feel the difference between just unpleasant pressure and actually that sensation of where the thumb is actually reaching the qi, and they can pick up on that quite quickly and see the difference. It's important to point out it should produce a pleasant sensation. It's not massage, but direct firm pressure to a specific area. They don't need to know any particular anatomy beforehand, and it's fantastic empowerment and promotes partner involvement in labour. And we know how often guys are complaining that they don't know what to do to help. They find it very difficult in labour to sit in the room and see their partner in discomfort, and feedback has been fantastic. For birth preparation, we're really focusing on San Yin Jiao, spleen 6, 3 yin in section for cervical ripening. So this is what they can start doing from 37 weeks after you've taught them what to do. And we encourage them to go home and do this at least for 5 or 10 minutes on each point. I said that they can just pop her feet up on his lap when they're sitting in the evening reading or watching television or whatever, and he can just put pressure on spleen 6 for 5 or 10 minutes, bilaterally or unilaterally, whatever suits them. The spleen, liver and kidney are all treated through this point. It's the cardinal point for all obstetric and gynecological disorders. Teach the birthing partners to do this every day from 37 weeks. And the feedback is that it's really fantastic to start the cervical ripening process. This isn't an induction of labour. It's about getting that cervix ready and moving forward towards going into labour. If she's on the verge of labour, it may well put her into labour, but it's really about preparing that cervix. We also encourage that as acupuncturists, you can teach midwives. We've taught 33 of our own midwives how to do this, and also to use acupressure during labour, and they're absolutely loving it and finding it really helpful. So my only tip about spleen 6 is that to make sure that the point location is correct. I have had a few ladies coming back to say that they've felt like this bruising on the tibia where they have been pressing too far forward. So just to check before they leave you that you're really happy with where they're pressing for their spleen 6 to make sure it's in the right location. Otherwise it's uncomfortable, and that's not going to be helpful at all. Okay, so here's the DVD again. My way of doing this is to get patients to come up, and I include the DVD as part of the appointment. I don't actually charge them a lot. I just charge them for the time it takes to teach them, and as I say, they go home with the DVD in their hand. This means they can replay the point location. It's a really good demonstration. Very easy to follow DVD. It's only half an hour long, and includes using Moxa and also using Moxa postnatally. I really do recommend it. Also recently, I actually had the privilege of having Deborah staying with me when the iPhone app came out. It is being worked on to be made available for Android phone, but they're not quite ready for that yet. But if partners have an iPhone, they can easily get the app. I think it's £2.99 in the UK, and I have been asked by midwives who I've taught and husbands and partners, oh, this would be such a great app, and then you could have the information in your pocket during the birth in case you forgot what you were doing. Well, there, and pleased to say now there it is. Okay, so moving on to acupuncture for pre-birth preparation. There are different schools of thought. Deborah Betts in New Zealand advocates using stomach 36, gallbladder 34, bladder 62 and spleen 6 once per week from 37 weeks until delivery. And in Germany, Ansgar Romer has midwives using what he calls the Mannheim model. And this is using stomach 36, gallbladder 34, spleen 6 and bladder 67 once per week from 36 weeks until delivery. And they are finding that they're getting very good results with this and less need for induction of labour and more efficient labours. So as acupuncturists, this is something we can easily implement, backed up with the acupressure, as I've just mentioned, to spleen 6, and you should be on to a real winner. So assessing changes, you may be familiar with the Bishop score. This is a pre-labour scoring system to assist in predicting whether induction of labour may be required. A score of under 5 is considered unfavourable, and with intact membranes and no regular contractions, the a hospital would recommend cervical ripening with prostaglandins to induce labour, such as Propes or Prostin. And if the Bishop's score is over 6, this means that the woman is favourable for an induction of labour with ruptured membranes, which they can either do artificially or may have happened spontaneously. And this means that they can put up the drip of syntocinon or pitocin or other such names. So by vaginal examination, the midwife can assess the position of the cervix. So before she's ready for labour, the cervix is quite hard to reach. It's quite posterior. And nearer labour, it becomes much further forward. So her score goes up to 2 for an anterior cervix. Before labour starts, the cervix feels quite firm. And nearer labour, it becomes quite soft. Effacement is how much of the cervix has been pulled up to be part of the lower segment of the uterus. And you can see the different percentages there. And this will give you a guide to how close labour is to beginning. If the cervix is closed, then obviously labour isn't about to start. And if it's 3 to 4 centimetres or over 5 centimetres, then certainly over 5 centimetres, then she must pretty well be in good labour. And the baby station refers to the height of the baby's head above the ischial spines, which is among the pelvis. And as you can see, -3 means that it's still quite high, and as it comes down, it becomes nearer and nearer. So this is all put together. It has to be said that it's important to differentiate between first baby and subsequent babies, because once a woman has had a baby, her cervix never really goes back to being closed. This is called a multips os, and it's because the cervix, having been stretched up, if she's had a vaginal delivery previously, will have reached 10 centimetres and never quite closes down. So this is taken into account when the Bishop's score is assessed. Induction of labour. Well, it's more than just points to stimulate contractions. We need to think about, is she prepared for labour emotionally and physically? Is the baby prepared for labour? What position is the baby in? To be in a good position to sit on the cervix and to help push it open. So this is very important when we look at things like posterior positions when the baby's lying back to back. What can the woman do to help herself get her baby into the best position? One of the most important things is her posture, and I think it's really important to encourage women not to sit on a soft sofa or armchair where their bottom is lower than their knees. They sink back into this furniture, and the baby just sort of flops towards their back. Rather, they should be sitting up forward, maybe on a birthing ball if they have one, or sitting cowboy style on a chair with a back leaning forward, and certainly not on a soft sofa as before. Women used to be scrubbing floors down on their hands and knees, and their babies used to engage in their pelvis nicely in this position. I'm not suggesting they all get down and scrub floors, but it's really important to educate them about good positioning to get their baby in the best position for labour. What starts labour off? Well, we still don't really know. There's all sorts of theories to do with baby and the mum. We know there's hormones involved. Estrogen, known as the love hormone. We know that sperm contains prostaglandins, so women are advised to make love in order to get them into labour. Women have tried all sorts of things. Curries, castor oil, cod liver oil, things that put them in a different space instead of focusing on the fact that they may be overdue. I was a week overdue with my second baby and fed up with sitting around waiting for labour to happen. And my husband took me out to see a film, which was very funny, and I laughed the whole way through. came home, got into bed, and my membranes ruptured. This not only got me a new mattress, but I'm sure it was to do with the fact that I had stopped focusing on when I was going to go into labour and had a good old laugh, which shook up my waters enough to put some strain on the membranes, and that was enough to get me into labour. There are studies showing that there are factors influencing the onset of labour. One study was published in the British Journal of Obs and Gynae in 2008, a large study looking at 186,000 women who were post-dates. This is defined as 42 plus weeks of pregnancy, or over 294 days. And women with a high maternal BMI in the first trimester and a greater change in BMI in pregnancy were associated with longer gestation and a higher risk of post-dates pregnancy. These women were less likely to go into spontaneous labour at term. This is interesting to me because obesity is becoming more and more of a problem. So not only do these women have other risk factors associated with high BMI, they're also more likely to need induction of labour, which is another potential stress on their system and increases their risk factors. We also know that statistically, women who are underweight are more likely to deliver preterm. So that brings up the question of the role of nutrition being involved in the timing of the onset of labour. What can we do to help our women understand that they really do need to be in the best possible condition before embarking on a pregnancy? This is possibility operating through the endocrine systems, but we need to understand it an awful lot more. What are the signs of the onset of labour? A lot of women aren't sure what's going to happen. We'll talk about that when we talk about labour. So when exactly is term? Well, it's defined as 37 to 42 weeks. It's not actually 40 weeks per se. Women are given a date based on 40 weeks from the first date of their last period. But if you look at a graph on when most women deliver, it's between 37 and 42, and it does actually peak at around 40. This is why 40 weeks is chosen as the date. I do think it would be better to give women a range of dates personally, then they wouldn't be so focused on one particular date and the fact that they've gone 7 days beyond it, because it can get them into such a state. It also means that half the family is phoning up saying, "Have you had it yet?" which isn't very helpful. In terms of maturity, the baby's lungs are mature at 37 weeks. So it's fine to go into labour then. It isn't a preterm birth. Premature birth is defined as 36 weeks. At 42 weeks, we do know that the placenta starts to fail. Delivering placentas of women who are post-dates, who've gone beyond 42 weeks, and examining them, we do find that the placenta has calcium deposits in it and feels quite gritty to touch and is less efficient. So there are risks associated with going beyond 42 weeks. Acupuncture has a fantastic role to play here. Pre-birth, I've mentioned, and self-help with acupressure can all do a massive amount to avoid our patients having a medical induction of labour. It's very unusual for a woman to actually want to have a medical induction. So, what is induction of labour? It's to bring forward the onset of labour. Sometimes women are offered a membrane sweep. This is where the midwife will do a vaginal examination, and this stimulates the cervix to produce hormones that may trigger labour. It shouldn't be too uncomfortable, but it depends a little bit on the position of the cervix. As I said earlier, the cervix can be quite posterior, and this means the midwife has to reach quite a lot. This can be quite uncomfortable. Also, if she can, the midwife will put her finger through the cervix and literally sweep her finger across the membranes that are covering the baby's head. This stretching of the cervix can be a bit uncomfortable. Sometimes the woman will have a little bit of bleeding afterwards or a heavier show. This is normal. and she just should be reassured by that. Otherwise, the hospital will use prostaglandins to ripen the cervix, as I mentioned earlier on. This is usually in the form of a vaginal gel or pessary. It depends on where you are. And when the cervix is open enough, which means really 3 centimeters, they can perform an artificial rupture of membranes, which you may see abbreviated in the notes as an ARM. If she starts having regular contractions, this is all that happens, or she may need a syntocinon infusion. It may be called another name, depending on where you are. Syntocinon infusion gives a hormone. It's very carefully controlled because it's important not to overstimulate the uterus. And this gets the uterus contracting. Reasons to induce labour medically may be to do with the baby. Maybe the baby isn't growing very well. Maybe it's not moving well enough. May I add here that it's really important whenever you see a pregnant woman after 28, 30 weeks to ask about her fetal movements. They are a good sign of fetal well-being, and it's really important that you know she's feeling a good 10 movements per day through her pregnancy. And even at this late stage. Having said that, some babies do go a little bit quieter at the end of the pregnancy. Some go the other way and seem to leap about all over the place. But she should still be feeling 10 good movements per day. There may be medical reasons for inducing labour early, before term or before 42 weeks in the mother. For instance, diabetes, whether it's gestational diabetes or insulin-dependent diabetics who get pregnant. Or she may be showing signs of developing preeclampsia. Her blood pressure might be going up. She might be having an increasing amount of protein in her urine. She might start having headaches and severe edema. These are all signs of preeclampsia. And in order to stop this developing further into eclampsia, the hospital may want to induce her early. Or there may be something to do with both of them as a reason. Induction of labour with acupressure. Again, this is something we can teach our patients and their birthing partners. And what you're doing is aiming to establish contractions and promote cervical dilatation. Midwifery feedback, where this has been used, suggests noticeable changes in the cervical ripening. As obviously, they get this from the Bishop's School. And there's an increased chance of a woman progressing through a medical induction with minimal intervention. So even if your acupressure induction hasn't actually got her into labour, if she does have to have a medical induction, it's much less likely to be long and laborious. Sometimes women don't respond very quickly to the prostin or pessaries or gels. They may have to have it repeated. For some women, they go into labour quite quickly. For some women, they have days of real discomfort with strong contractions that are really working to try and get that cervix opening, but without success. I think this is often to do with the position of the baby and that needs addressing. But if we can avoid this for them, it's really worthwhile. Something they can do for themselves, taught by us as part of the induction process, and hopefully to help avoid a medical induction, and complement using acupuncture for induction of labour. It can be started 2 to 3 days prior to a medical induction if possible. Points like large intestine 4 and spleen 6 can be used every 2 hours. She can do large intestine 4 for herself, possibly even reach spleen 6 if she's quite flexible. Bladder 32 and gallbladder 21 can be done twice a day by a partner or a friend. And it can be done frequently if there's less available time. So, acupuncture for induction of labour. It's absolutely vital to address the individual and constitutional issues here. When I first started using acupuncture for induction, there really wasn't anybody to ask what I should be doing, and I just went on what I read in the textbooks. And I'm afraid I did actually just try using points to stimulate the uterus. I've learnt an awful lot since then. My success rate is much better since I've been addressing other issues rather than just stimulating contractions. So points we know stimulate the uterus, colon 4 and spleen 6, particularly in conjunction together, gallbladder 21, bladder 60, bladder 67, bladder 31, 32 and 33. But as I said, emotional issues are important too. We know that in TCM, emotions have a massive effect on the organs, the flow of qi and blood. And I've loosely written here about effect on the kidney and spleen. You will know yourselves that this isn't the whole picture. There may be somebody who's had a recent bereavement and may have affected her lungs. You know these things yourselves. But it's important to think about other issues. A study from the British Medical Journal back in 1979, it's an old study, but it was interesting to me because it looked at the effects of stress, and premature labour was shown to be much more likely if women had had stressful events. It was a study looking at 132 women, but it really was an interesting indication of the effect of stress. Makes you wonder whether we should stress our patients to get them into labour, but I'm not really advocating that. I'll just share with you a couple of case studies about how we can do so much for women at this stage of pregnancy, and it's not just about, as I say, sticking in needles to stimulate contractions. The first one is a lady called Victoria. She's 29 years old, and I saw her at 39 weeks and 4 days. She was gravida 3 para 2, so it was her third baby. She'd been feeling very low for a month. Her first baby was now 9 years old and had been born by a ventouse, which is the suction type apparatus they use, because he was back to back. Her second baby was born at term, and she was referred to me by her midwife, who was very worried about her mental state. She'd never been like this before. She was extremely tearful, which wasn't usual for her. She had no appetite. She was used to working. She had pelvic pain, and she'd had 3 urinary tract infections in pregnancy. She had no postnatal depression or depression in the past, so this mental state was very unusual for her. No anxiety particularly regarding the labour. She felt quite fine about that. Her sleep was terrible. She was waking frequently. She also had heartburn, so she didn't eat after 5:30 or drink because it made it so much worse. But she had to get up to pee during the night. Her pelvic pain was worse at night. She didn't have any headaches. Her bowels were open daily. She wasn't constipated. She wasn't dreaming, but when she did sleep, she slept deeply. She felt very angry and agitated, particularly by her mum, and there were massive problems with their relationship. I found this very interesting and the absolute key to what was going on. As I said earlier on, people don't really mean to be a bother, but they can't help themselves phoning, particularly family members, when somebody's baby is due and asking what's going on any day from the day that the baby's due or even beforehand, and it can put massive pressure on them. This relationship with this woman's mother was really affecting her emotionally. And of course, you know, she's just about to become a mum again herself, so it's more complex. I treated her with yin tang, Baihui, GV20, pericardium 6, Nig 1, Sanin Jiao, spleen 6, and Tai Chong, liver 3. She very much had a picture of stagnation of liver qi. I used pericardium 6 for its lovely effect on that heaviness in the chest with sighing. I find it's a wonderful point for that type of picture. I wasn't trying to induce her. It was really more for me that day about trying to get her in a better place and, importantly, get her in good condition to go into labour. I gave her an appointment to see me the following week, but she cancelled it as she delivered 2 days later after this treatment. She felt wonderful after the treatment. Her anger dissipated. She felt relaxed and calm. And to me, this was what helped put her into labour. So there's just an example about the importance of treating the person at a time like this. Preparation for labour, getting her in a good place so that she can deliver safely and efficiently. The second example was quite the opposite. There's a lady called Lisa who was 35 years old. I saw her at 39 plus weeks, and this was her 4th baby. All her previous labours had been precipitate labours at home. And a precipitate labour is a labour that goes so fast you hardly have any warning. Now, a lot of people would say, oh, how wonderful, I'd like to have that. But actually, if you talk to people who've had them, they're awful. They're too fast and they're a real shock. Somewhere along the middle of the road would be much more acceptable. So this lady was referred to me originally because they thought she might have a breech presentation. But in fact, when I saw her, the baby wasn't breech, but was very mobile and kept moving around. So she came back to me after her scan and wanted to have a chat about her consultant wanted to have a home birth. And this was because, having had 4 babies already, her 5th labour put her at risk of postpartum hemorrhage because the uterus doesn't contract down quite so efficiently after the birth, and this increases the risk of postpartum hemorrhage. She lived quite a long way from the hospital down in Cornwall, which would be probably at least a 30-minute, if not 40-minute journey, even by ambulance. So they were worried that she would have complications. So she came to talk to me about induction of labour, which she was very anti. She really didn't want to come into hospital. She had a fear of hospitals and certainly didn't want to be induced. So the consultant agreed that she could have acupuncture induction of labour, which was the only type of induction she would agree to. So on the day that was prearranged, we met on the ward. All was well. Everything was all right with the baby. I taught her partner, Robin, how to do acupressure on kidney 1 because she was extremely fearful. And I started to try some points to get contractions going. We haven't got time to go into too much detail about what I did, but I can tell you that I tried absolutely everything according to her TCM picture and every other trick I could think of in the book. I was running from seeing her on the delivery suite back to my clinic to try and see some patients and back down again all day. I really wasn't happy with what I was doing. I felt I was being coerced into treatment that I didn't feel happy with. At the end of the day, I talked to the consultant again and said I really felt this was a waste of time. In my experience, she should have been responding much better to the treatment she'd been having had she been ready to go into labour, and I just didn't feel she was ready. She'd also had enough. She discharged herself and told them that she wasn't keen to carry on, and she went home. I got a phone call to say that she went into labour, and she again had a normal birth very quickly at home without any complications. So this is an example of no matter what you do, there will be patients where the body just isn't ready to go into labour. For whatever reason, the baby's not ready, she's not ready, nature just isn't ready. So you can hammer away with needles till the cows come home, but you still won't get her into labour. So it's all about looking at the case. As I said, she was only 39 weeks. She wasn't ready, and acupuncture just isn't going to work in these situations. Patients will try and persuade you to get them going quite early sometimes, partly because they've basically been pregnant for a long time and have had enough. Sometimes you get social reasons for wanting to go into labour. In Plymouth, we have a lot of naval families, and if husbands are due to go back to sea and they have a short leave available, then women will sometimes plead with you to try and get things going so that their husband can see the baby before they go back to sea. But as I say, it may be a waste of time. By all means, see her and treat constitutional things, get her ready for labour. But in terms of actually using needles to try and stimulate the uterus when it's not ready, in my experience, doesn't get you very far. Quick look at the research available. There is more recent than this, but these are kind of handy if you want to make a case for having acupressure or acupuncture available, and when you're talking to your local maternity units and midwives in terms of the fact that it's worth referring women, because some of these studies are showing that acupuncture and acupressure can be very useful in terms of getting things ready. Okay, so moving on to actual pain relief in labour when the woman's actually in established labour, and this is pain relief when needed. It's very variable. Some women have higher pain thresholds than others, need pain relief very early in the labour. Others feel they can cope quite well, particularly if they're at home in their own surroundings. They're using a bath to relax themselves, or they may have a water pool available. So the time of labour that analgesia is needed is obviously very individual. If she's beginning to feel, oh, I really need something now, that's when you need to start. We are going to move on and talk about acupressure, but for now we're talking about acupuncture. As I said earlier on, when I started doing this, it was the 1980s, and there were very few people using acupuncture for pain relief in labour. I had to go on the texts which told me to use points like colon 4, spleen 6, bladder 32. Well, that wasn't much use for a woman who's having strong contractions and needing to move. The needles were in the way. I was worried about them getting into the wrong location, causing damage. I really wasn't happy with what I was doing. So I switched to using auricular acupuncture. Points were Shen Men, uterus and endocrine. And I would attach the electrodes, which would be controlled by the woman. So using a small electroacupuncture machine. The picture you have here is a TENS machine, but initially I used my good old-fashioned GQ10C machine that I'd brought back from China. Quite a large contraption, but now we've moved to a smaller machine which we get from Scarborough's, which is a much more easy to use machine, at pocket size, easy to use machine, a bit the TENS machine in size. So I would use 1/2-inch needles to each of these auricular points, Shen Men and uterus at the top of the ear and endocrine at the bottom. Endocrine is an awkward position at the bottom of the ear there, and a lot of women find it quite uncomfortable. If you're not familiar with needling, I suggest you get them to do a good deep breath in and out as you put endocrine in. You do need your needles, 1/2-inch acupuncture needles, to be anchored quite well into the cartilage, because she's going to be moving around, particularly when she's getting contractions, and it's going to be quite sore if you have to keep reinserting them. So you do need to get a good anchoring with your needle. You need to use copper-handled needles if you're going to use electro to conduct the electricity. So I'd put my needles in, tape them down, and because you're using electro, you've got a positive and a negative electrode. You don't really touch each other. So I suggest you put the electro on either uterus or Shen Men at the top and your other electrode on endocrine. Then they're further away from each other. I've tried using negative on endocrine and positive at the top, and I've tried it the other way around. It doesn't seem to make much difference in my experience. You can use a cotton wool ball in between the top needles and the bottom needles if you're worried about them shorting out, and that seems to work quite nicely. If the needles do fall out, no worries, just replace them. And if it's a long labour, and I have looked after a girl having her first baby for 15 hours just using electroacupuncture, we swapped the needles over to the other ear to give it a break, and you can do that one or more times if you wish. So I found this a very efficient way of using acupuncture in labour. Other people will have different ways and methods. This is just what we found useful in Plymouth, and we used it on a substantial number of women. If you're using electroacupuncture, you do need to keep it away from the monitor. If she's having the baby's heartbeat monitored with a CTG or cardiotocograph machine, it will potentially interfere with it. So keep your electroacupuncture machine on the other side from the monitor if it's being used. And fairly obviously disconnect the electro if it's a water birth. You can still leave the ear needles in, and you could manually stimulate them, but again, bearing in mind it might be a long time, just be careful not to make it too sore. So this is what we found useful. It gives the woman the ability to move around. Yes, she's got her electrodes down. She controls the stimulation herself. So you have your intensity at a low setting to start with. And the idea is very similar to the obstetric TENS machine. TENS machines normally, when being worn by non-pregnant people for backache or whatever, just to have the electro unit. But an obstetric TENS machine will have a boosting button. And when the woman gets the contraction, she presses this boost button and a surge of stimulation goes through the pads, which are worn on her back. Similarly, with an electroacupuncture machine, she's in charge. She has a comfortable sensation traveling through the needles all the time, and when she gets a contraction, she whacks it up as high as she wants it, and then back down again when the contraction's gone. And you'll notice as labour progresses that she's turning her intensity up more and more. Most electroacupuncture machines have two intensity settings, one low, one high. Obviously start on low, and then you can move to high later on as labour becomes more intense. And in my experience, I've only had one woman who got to the top of the dial on the high intensity. And as I said to her, I'm afraid I can't turn it up anymore. We're going to have to plug you into the mains. She said, it's okay, I think I need to push. And sure enough, she was in the second stage of labour, so we were fine. That's my experience of using electroacupuncture with the ear points in labour, and I do recommend it. Obviously, you can use body needling to progress, or she's having weak contractions. You can use points like colon 4, spleen 6, stomach 36, bladder 23 if you feel that she's very deficient. If you feel it's because of stagnation, colon 4, spleen 6, bladder 67 and liver 3 may be helpful. If it's because the baby's not in a good position, and the midwife will know this from either the vaginal examination or abdominal palpation, points like bladder 67, bladder 60 and gallbladder 21 can be very helpful. And if there's a cervical lip, bladder 32 and liver 3, this is where she's near the end of the first stage of labour. The cervix is dilated about, 9 centimetres, but there's a little bit of cervix that's got trapped in front of the baby's head, and very uncomfortable and very difficult for the women not to push at this stage, because the baby's head has descended a bit, so it feels like she wants to push, but when the midwife examines her, she finds a little bit of cervix there getting in the way and holding that baby's head back. If she pushes on this cervix too early, it's going to become edematous, and that's going to make the situation worse. So these points are really useful in this situation. And obviously, if she's having weak contractions and she's not in really strong labour, it's fine to use these points. She's not going to be thrashing around. But when a woman's in good, strong, established labour, she's mostly going to want to move. So this is why the body points aren't very easy to use. Some people use them. They tape them down. Personally, I favour using ear points instead, because I'm too worried about her not being able to get into the position she wants to get in. Okay, so you can use your acupuncture the whole way through the labour, and you may find that you want to take the needles out maybe during the second stage of labour when she's pushing. Personally, I think that's a little bit invasive. Probably best to wait till the baby's actually born. And it's quite nice to quickly get them out then and get out the way so that the couple can spend time with their baby, bonding without any contraptions or needles. If it doesn't feel appropriate, just leave them in. Maybe detach the electrodes, but leave the needles in place if it doesn't feel right to be going in and taking needles out at this stage. It doesn't really matter. And we're not really covering postnatal here today, but as it's part of labour, remember that gallbladder 21 is a fantastic point for retained placenta if the placenta isn't delivered. And it's also a good idea to teach it when you're doing acupressure teaching to partners, because you may not be available at the birth, but they can do an awful lot to help get the placenta out. I'll talk about that when we talk about acupressure for birth. So if you're in the patient's home and the midwife's there and it's all been a lovely home delivery, that's absolutely fantastic. If you've never attended a birth before or you've never had a baby before, I'm going to just talk about a few emergencies which may be encountered. If you're in a hospital setting, attending as a birth partner or as an acupuncturist at a birth, just to be aware of a few things that may happen. It could be a bit of a surprise otherwise if you're not familiar. Maternal distress. Well, labour's a very intense process, more so for some women than others. I've actually seen a husband's t-shirt ripped straight off his chest by a woman at the height of a contraction as she screamed at him that it was all his fault, and the poor chap stood there in women have been known to swear unbelievably, despite being very well spoken and demure and very well controlled the rest of the time. So don't be surprised if you see somebody turn into somebody that you don't recognize. Fetal distress, well, this is where the heartbeat starts dipping. It's always very frightening. In a home birth situation, the midwife will be listening to the heartbeat, usually with some sort of Doppler type device, so you can actually hear the baby's heartbeat. Or she may be even using an old-fashioned Pinard stethoscope, which is that little triangular device that you see the woman having put on her tummy, so the midwife can hear the heartbeat. But if she's in hospital and got the CTG machine on, you can actually hear the heartbeat and see it on a graph, and you can actually see the dips. This is where the baby's oxygen supply being reduced during the contraction. Some dips on the heartbeat are fine, some are not so fine, and the midwife will be trained to recognise when it's not so fine. So just to point out to you that the baby's heartbeat can dip during contractions, and sometimes it can dip down and stay down. And don't be surprised if you're the acupuncturist attending the birth, if people start getting a little bit stressed about this. Doctors start coming in the room, looking at the heartbeat trace and recommending other procedures. Sometimes they will take a sample of blood from the baby's head by doing a vaginal examination and using a probe to get a little bit of blood, and this is then analysed, and will tell the doctors and midwives whether the baby's getting into real trouble and whether they need to proceed to a cesarean section. This fetal blood sampling. Cord prolapse, well, it's rare, but it can happen. And just to point out, and obviously you can see here, the cord has slipped down below the baby's head and is trapping the baby's blood and oxygen supply. It is an obstetric emergency. If it's at home, then an ambulance will be called immediately. The woman will be put into different positions. You can see on the picture here on the left, there's the midwife's hand, a gloved hand, examining the cord after the birth. Look at the size of those big, juicy blood vessels. And so you can see how important it is that very important supply isn't cut off. The woman's put into the knee-chest position, or she can be put on her side with her pelvis raised. So I hope you never see it. If you're in the hospital, you may find that the midwife puts her fingers in and holds the baby's head up away from the cord as she goes down the corridor to theatre. This woman will have to have an emergency cesarean section. The baby can't be born vaginally safely in this situation. So it is an obstetric emergency. An intrapartum hemorrhage, again, it's not usual, but if it happens, it may be that the placenta is separated and that she will have to be hurtled off to theatre pretty quickly. At the birth, you may see that the situation of shoulder dystocia. This is where usually it's a very big baby and the baby's head is delivered, but the shoulders don't do their rotation in the pelvis and get stuck. It's another obstetric emergency, and doctors and midwives will be getting the woman into peculiar positions and doing various manoeuvres to try and get the baby born. Retained placentas when the placenta isn't delivered safely. Women now often have a managed third stage of labour, so they have an injection to help the placenta separate. This is done when the baby's shoulders are beginning to be born. But women may choose to have a physiological or a natural third stage of labour, as I did myself in both my births. So the placenta is allowed to separate naturally, and this should happen in about the first 5 minutes or so, maybe longer with a physiological third stage. But if it still doesn't appear, there is a risk of hemorrhage. So we can do something if we're in a position to, either, as I said earlier, by teaching partners how to press gallbladder 21 really firmly. When we're trying to get a placenta out, the woman should be really feeling that point pressed. Really strong dirty sensation, important here. If you're there as an acupuncturist, you can needle gallbladder 21. Remember, of course, it does have a danger with the lungs, but you do still need to get strong chi. And postpartum hemorrhage. This is slightly more common than these other situations, and it can be quite alarming. The placental bed in the uterus is quite large, and there are big blood vessels. You saw the size of the blood vessels in the cord. There are big blood vessels leading from the placental site on the wall of the uterus to feed those big blood vessels, and the women can bleed quite substantially. Again, the midwives will be there. They know what to do. They will be trying to get the uterus to contract. It's called rubbing up a contraction, by putting their hand on the woman's abdomen and getting the uterus to respond. She'll have a drip put up with hormones to get the uterus to contract down, and hopefully the situation will be contained. So a bit scary, but important to know about, just in case you happen to see it, and you'll have a better understanding of what's going on. And you can play your part by helping to reassure her, comfort her, but the professionals may not be able to do that, as they'll be too busy coping with the emergency, which is important that they get on with. Okay, so moving on now to acupressure, promoting partner involvement. we are absolutely passionate about this. We have really moved over to using acupressure much more during labour as its form of pain relief, because we have great problems in being available as an acupuncturist during labour. I'll talk at the end about acupuncture for childbirth teams, but really if you're promising a woman acupuncture in labour, you really do need to be on call every day from 37 weeks to 42 weeks. I used to find this, a privilege, but also quite an interruption to your lifestyle. So if you're going to promise it, you really do need to be available. So acupressure can be available 24/7, 7 days a week, by teaching it to the partners of the birthing woman or a birthing partner, if she has a doula, for instance, coming in to be with her, or it may be her sister or her mum or a friend. Whoever's going to be her birthing partner can be taught acupressure, or it can be the father of the baby, her husband or her partner, and we are absolutely delighted with the results since we've been using acupressure for pain relief in labour. We have a large folder of testimonials from couples as evidence of its efficacy. Well, the advantages are fairly obvious. It's a non-invasive technique. It's accessible, it's effective, and it's safe. Midwives and support people. It promotes the birthing partner involvement, as I said earlier, gives the guys something to do. They're really finding this a fantastic experience, particularly when they've compared it to a previous birth where they haven't had much of a role to play. Makes a massive difference, and I think this has huge implications for the whole bonding experience for the family. Support people are providing general pain relief through the woman's feedback, so she's telling them they're working together and it's very much a team effort. It can be started at home when the labour begins. You don't have to wait for them to get to the hospital. As soon as she's feeling like she needs some pain relief, that's the best time to start. And midwives can be taught to use it for treating specific conditions, pre, during and post-labour. For instance, as I said, for retained placenta, or if the contractions slow down. And it reduces the need for intervention. Women who are relaxed and having good pain relief are much likely to need less intervention. Much less likely to need intervention. So as I said earlier on, in terms of teaching acupressure, patients can be encouraged to download the free booklet from Deborah Bett's website and practitioner handouts. It's the application of pressure to acupuncture points. Teach them it's the points situated on meridians containing chi that flow through the body. Keep the teaching sessions simple. Show them the charts or whatever if you have your little models in your clinic. This whole concept of chi flow and how the different areas are connected. And looking at the ancient texts, I thought this was rather nice, from the Birth Treasury 67 CE. In my household, all women and girls are taught personally how to doctor themselves. Then in childbirth, they all know how to save the situation. It is proper for families to instruct orally so the household knows this. So this idea about passing on, and of course, couples talk a lot about their birth experiences, and I dream of a day when women are all telling each other about how wonderful acupressure is for birth, and the need for drugs goes down substantially. And looking at a Cochrane review from 2003, which looked at continuous support for women in labour, they noted that women who had support during labour, whether it was advice, assistance and emotional support, were more likely to have a spontaneous vaginal birth. And it was associated with greater benefits when the provider was not a member of staff and when it began early in labour. And that review was looking at 12,000 women, so quite a substantial number. So it's fairly obvious, really, but a woman who comes into labour who's on her own, isolated, frightened, and is being looked after by strangers is obviously not going to do so well as somebody who has somebody familiar with them providing their care, preferably their partner or birthing partner, or an acupuncturist that they've got a good relationship with. Practical use in labour. Well, the partner or person using it early, and we know that this gives the better results. It's better not to wait till she's absolutely climbing the wall. So start early in labour as soon as she's beginning to feel uncomfortable. The partner providing or person providing the pressure is guided by the woman's feedback as to the point selection, because as labour progresses, she's going to want the pressure in different places. Our experience is that most women like to start with gallbladder 21. It's an easily accessible point. If she's sitting in a chair, somebody can stand behind on gallbladder 21, either with their thumbs or their elbows. But as labour progresses, most women will then want the pressure to be on their low back. It doesn't really matter. They should be the one that's choosing as to what they want. And some women will get a bit irritable and not want pressure in certain places. And we advise that the partner doesn't give up, but try different points, because usually they'll find the magic place. It's pressure, not massage. And as I said earlier on, it's important to teach what this pressure should actually feel like to the person who's actually giving it. It should be to her comfort level. It shouldn't feel painful or sore. It should actually be a feeling of, oh yes, that's right, that's where I want it. And if it feels no longer effective, move on to different points. Coming back to the DVD, it gives a lovely account, and there are patients on the DVD, most of whom are ours actually from Plymouth or from my home practice, talking about their experiences, and it really does bring it to life, which is rather nice. I have a testimonial from a couple I'd like to share with you. From my 28th week of pregnancy, I had SPD, that's pelvic pain, and was referred for acupuncture. I was unable to drive, confined to bed, and had to rely on crutches. After several weekly acupuncture treatments, my symptoms were significantly relieved, and I was able to walk without crutches before delivery. In my previous pregnancy, I requested an epidural, had nerve vaginal damage, possibly as the result of using the stirrups for the delivery, and undiagnosed pelvic pain. I consequently suffered 2 years of discomfort and was keen to avoid a repeat of this. So my husband and I attended an acupressure seminar and learnt how to use this technique to relieve labour pain. We watched an informative DVD, were given supportive literature, and had the opportunity to practice techniques with Sarah present. All of this was also linked to an easy-to-follow website. We downloaded the detailed literature, which provided acupressure points for each stage of labour. Indeed, in my final treatment, Sarah encouraged labour by using the appropriate acupuncture points, and I delivered 2 weeks early. During the onset of labour, I made use of the pressure point between the thumb and index finger, Hogu. My contractions were very irregular at this stage, and after 30 minutes of using this pressure point, they became more regular and increased in intensity. After 1.5 hours, I phoned the hospital, as this was my second pregnancy, and was invited to go to the hospital. I was assessed as 4 centimetres dilated and offered the opportunity to stay for a few hours until established labour began. At this point, my husband applied pressure on my shoulder blades, and I found this gave immense relief, taking the edge off the more painful contractions. We continued to use this pressure point throughout the rest of labour. We tried applying pressure on my lower back, but this wasn't helpful. I found the pressure applied on my shoulders gave the most relief when in the standing position, and continued to labour until the second stage in this position. Established labour lasted 3 hours, and in the final hour I also used some gas and air. I found that when using gas and air, if my husband removed pressure on my shoulders, the contractions increased dramatically in intensity. It was only the combined use of acupressure and gas and air that provided relief. As a pelvic pain sufferer, I was concerned that the second stage might cause damage and consequently chose to deliver my baby on my side. This final pushing stage only lasted 5 minutes, and I believe that the acupressure helped speed the process up. Throughout the second stage, pressure continued to be applied on my shoulders. Having been very anxious about this pregnancy and birth, I can honestly say that acupuncture during pregnancy and acupressure during labour were wonderful. As someone with a low pain threshold, I couldn't have imagined how effective acupressure would be as a method of pain relief. We're so pleased we were able to have the opportunity to learn more about this technique and would unreservedly recommend it to any expectant couple. My husband felt empowered, and I was extremely grateful for the relief he provided, and we were able to deliver our baby in half the time of our first child's birth, etc., etc. This is typical of the sort of testimonials we've been given, and I think it's a lovely illustration of the power of acupressure during birth. Other patients have commented on how when the support person had to take their hands away, for instance, if they needed to leave the room to go to the loo or to get a drink, the intensity of the contractions immediately increased dramatically. And that's a really good illustration of the power of how helpful this pressure can be. It may not work for everybody, but it doesn't stop them having other forms of pain relief. It can be taught from 36 to 37 weeks in a half-hour session, as I said earlier on, maybe in groups. And if she does need further pain relief, it's still an option. As you can see, that lady had gas and air at the end, which is the least of all the pain relief offered medically, as it wears off quite quickly. I would encourage you to keep testimonials and a portfolio on your experiences of pressure and acupuncture in birth, as they're really good in these days of everybody talking about evidence base. And to me, there's nothing like a story. I'd rather read testimonials any day over and above randomized controlled trials. I feel very strongly that the minute somebody's in a trial, it alters the whole experience anyway. So just to recap, very simple technique to teach. You're really only teaching 8 points. Jianjing, gallbladder 21 for contractions and retained placenta. Siliao, bladder 32 for contractions and backache. Yongchuan, kidney 1, fantastic point for fear and panic and the transition. Hegu, large intestine 4 for contractions and spleen 6, the same. Also, as I said, for cervical ripening. Kunlun, bladder 60 for fetal positioning and with the baby's head being high. Bladder 67 for posterior position, which causes its role in breech presentation with Moxa. And if the woman has nausea or vomiting in labour, simple to teach them how to press pericardium 6. Another patient I was treating in pregnancy, had a good relationship with her. She was a timid, mouse-like young girl, very fearful and full of tremendous anxiety about her birth. She was keen on using acupressure for her pain relief in labour, and her partner came up and learned how to use it in a group setting at 37 weeks. With this girl, I particularly focused on the use of kidney 1, because to me, the fear and panic was probably going to be more of an issue for her than the actual pain of the contractions. She came back to me and told me that she'd used kidney 1 throughout her labour and how much it had helped. She didn't need any of the other points for pain relief because kidney 1 was keeping her calm, and the calmness helped her cope with the pain of the contractions. So individualising, teaching patients well about which points might be helpful and getting them to perhaps play around with them depending on the stage of the labour. This is just a loose kind of look at the actions of the points. As we all know, there's much more to it than this. But when you're teaching, we don't want to confuse them too much. So you may want to adapt the paperwork, make your own list of points and what you suggest for different parts of the labour. You can turn it into a list where you have specific actions of the points. It doesn't really matter. I have to say, though, I found that the app and the DVD, but particularly the app, in terms of its instant reminder facility, which it has, was really fantastic for midwives or birthing partners or yourselves. Not so much yourselves, of course, but for anybody at the birth who wants reminding, oh, what do I need to do now? Where should I be pressing? And it has a really good facility for looking at that. So you can look at the points in a different way. For cervical lip, bladder 32, spleen 6, and I mentioned earlier on liver 3, these lists are not hard and fast. They're adaptable. People will have their own choices. They may even have other points they like to use. These are just the main points that we found particularly useful. Posterior positions. I've said earlier on about positioning. So important. The woman really earlier on in the pregnancy will hopefully be getting her baby into a good position nice and early on, because obviously the later in the pregnancy they don't tend to move around so much and can get fixed in a certain position. So sitting upright, sitting forward, sticking their bottom out at the back, so that the baby is more likely to have its back at the mother's front, occipito-anterior position, or OA, versus position back-to-back, OP position, occipito-posterior, which causes a different diameter of the baby's head to descend into the pelvis, larger diameter, and this is where it causes problems. It doesn't sit on the cervix and dilate it as well, and the uterus will work away at trying to get that baby's head into the pelvis. I had 2 posterior position labours, and believe me, they really are no fun. So positioning is crucial. One of the things you can try is putting ear press needles onto bladder 67, or using acupressure on bladder 60 and spleen 6 to help get that baby's head down and get it into an optimum position. Ear press needles can be put onto bladder 67 before labour and can be worn during labour even. May not be very popular in the winter with shoes on, so probably better with flip-flops. It's not a very easy point to put pressure on because of its location, and actually you really can't get good enough pressure with just the thumb. So when I'm teaching bladder 67 for acupressure, I usually recommend that they use something kind of sharp, but not obviously going to cut, like the top of a ballpoint pen, or if they've got fingernails, to use that if press needles aren't appropriate or aren't available. Problems during labour, posterior positions and deflexed heads, failure to progress, cervical lip, transition and retained placenta can all be helped by acupressure. In terms of some research, a study by Chung looked at the effects of colon 4 and bladder 67 on labour pain and uterine contractions, the first stage of labour. I mentioned earlier on about the study on continuous support for women and the potential outcomes, and a study by Ingram looking at the effects of shiatsu, or in other words acupressure, on post-term pregnancy. And Lee in 2004 looked at the effects of spleen 6 acupressure on labour pain and length of delivery time in women during labour. I've included a little glossary. Pregnant women usually carry their notes round with them from the hospital or the midwife, and it's a good idea to be familiar with these if you're going to be attending a birth, just because the terminology gets thrown around the room. You'll hear people talking about the APGAR score. This is an evaluation of the newborn's condition, and it's measured by looking at the heart rate, breathing, muscular tone, reflexes and colour. And it's a score given out of 10. And it really does give a good indication of the baby's condition at birth. Cardiotocograph, or CTG, this is the machine for monitoring the baby's heartbeat and the mother's contractions. It's a machine where she will have 2 belts round her tummy, one with a kind of large button on it at the top of the uterus, at the fundus of the uterus, and this will be picking up the tightening of the uterus, so measuring the contractions, and that'll come out as looking like a little hill on the graph where the pressure increases and goes away again during the contractions. The button will be over the baby's heartbeat, so usually, depending on the baby's position, lower down on the mum's abdomen. And as I said earlier on, recording the heartbeat on a graph coincidentally with the contractions, and this tells the professionals what actually is happening to the baby's heartbeat during the contraction, so you can actually see the timing of the heartbeat if it's dipping. Occasionally, if there is some reason why the heartbeat isn't being picked up well enough on the mum's abdomen, or if they're concerned about the baby's heartbeat and they want the most accurate recording, they will put a little gadget on the baby's head. It's called a fetal scalp electrode, or FSE, and it's like a small kind of crochet hook type device which is attached to the machine, and a little hook in the baby's scalp to pick up the heartbeat, and will give a more accurate recording. So you may see that this wire coming from the woman's vagina and leading onto the machine for the heartbeat monitoring. Effacement is where the cervix changes prior to and in earlier labour, and as I said earlier, the cervix starts off quite thick, and during the process of effacement starts to get pulled up into the lower segment of the uterus. So it stops becoming the neck of the womb and becomes more like a disc or a circle, and becomes thinner and thinner as it becomes more effaced. And usually when a woman is in established labour, the cervix feels completely different to before labour and feels thin and more circular. The fundal height is the top of the uterus, and it's measured to the upper border of the symphysis pubis. So sometimes you'll see a tape measure being used to make sure that the pregnancy is the right size, with the bottom end on the symphysis pubis and the top end where the top of the uterus is, so the height of the pregnancy. Lochia is the name given to the discharge following childbirth, and it changes as the days go by. A meconium is the baby's first bowel movement. It's a black, sticky substance, which we will all remember if we've ever changed a newborn baby's nappy. Occasionally you might hear that the baby's got meconium-stained liquor. This is where the baby's actually had its bowels open before it's born, and the meconium gets into the waters. It causes the waters to be quite brown, browny green, and it can be a sign that the baby hasn't been very happy in labour. One of the problems with meconium in the waters is that it's not good for the baby to inhale. So if there is meconium stained liquor, as it's called, then there will be probably certainly a midwife with a resuscitator type machine in the room, possibly a paediatrician, and the baby's mouth will be sucked out straight away using a suction machine to stop them inhaling, because it can cause quite a lot of damage to their respiratory system. A multigravida is shortened to a multip, and this is a woman who's been pregnant at least twice. And a primigravida or a primip, as the nickname goes, is a woman in her first pregnancy. So relevance to do with cervix and the state of the cervix, as I said earlier, but also multips tend to have faster labours than primips. I'm just going to show you a picture which you may have seen before if you've seen ours. This is the Putnam's cushion, fantastic for treating pregnant women. There's a patient called Lisa with needles in the back of her legs, being treated for hemorrhoids. She's got bladder 57 in there. I can't remember which other points, but this wedge type cushion is great if you're going to be treating a lot of pregnant women and worth investing in, particularly if you're going to be working in some sort of multi-bed type clinic, as they are a bit expensive. Textbooks I'd like to recommend to you. My favourite is Deborah Bett's book, The Essential Guide to Acupuncture in Pregnancy and Childbirth, published by the Journal of Chinese Medicine in Brighton in England. It's a wonderful text for treating any conditions in pregnancy, childbirth, and in the postnatal period. I find it really easy to use. I'm pleased to say we've worked along the similar lines over the years, and it's a great text. And there's another list of also recommended, but of course it's a bit confusing. There's always more than one way, isn't there? We all have our own favourites. My teaching today is possibly a bit westernized because of my background in midwifery, although I am a TCM acupuncturist, but I obviously have leanings that way. I put my hand up to that. But you will find conflicting advice. You'll have different ways of doing things, and some of the texts may actually conflict with what you've been taught or what you actually believe in. You'll see I've put next to Ansgar Romer's book, Medical Acupuncture in Pregnancy, Caution with Points. This is because Ansgar doesn't really believe in the forbidden points of pregnancy and will advocate using any point at any stage of pregnancy. So you have to make your own mind up about that. And we talked about pregnancy in the previous webinars. If you haven't seen them or heard them, I encourage you to read up about the forbidden points, because I think, first of all, it's important to do no harm, and I think at the moment we don't really know enough about the action of the points in terms of different gestation periods. I've given you a very quick sketch on the research. There are many more papers available. If you're going to make an approach to a medical hospital, a maternity unit, or doctors or midwives, they are going to want to have some evidence. Personally, I think there's more than one way of evidence than randomized controlled trials, but anyway, if you go to acupunctureresearch.org.uk, you'll find articles and then briefing papers listed. Obstetrics 1 and 2 are summaries of obstetric acupuncture, and they talk about the types of studies for different conditions, and also I've put them into table form in terms of the type of trial, whether it's an RCT or a case study or whatever, the acupuncture used and the outcomes and the sample size, etc., with references. Now, Obstetrics 1 is on nausea and vomiting in pregnancy, and it is quite out of date now, but it has got some a substantial number of studies. And Obstetrics 2 was updated in 2010. I'm not sure that they've got the updated version on there at the moment, but if you contact them, it is available, or you can contact me. I have it on my desktop. And that summarizes studies for acupuncture treatment during pregnancy for various conditions, particularly pelvic pain and breech, etc., but also induction of labour and pain relief in labour. The British Acupuncture Council have research fact sheets under the title of obstetrics or childbirth or pregnancy, and they are updated quite frequently by Mark Bovey, who's the research officer at the BACC. And I think the recent ones, the most recent are 2010, but he does update them periodically. So have a look. You can find ways of getting the studies and be familiar with the research that's out there. Systematic reviews are being conducted all the time. And in the UK, a lot of emphasis is put on whether NICE, the National Institute of Clinical Excellence, are condoning acupuncture. But of course, they're always playing catch up. Just because the evidence isn't there for them on their site doesn't mean that the evidence doesn't exist. So it's important to keep aware of the latest research and have some idea about what the studies are saying in terms of efficacy of acupuncture for induction and pain relief in labour. I talked earlier about the problems of providing acupuncture for pain relief in labour. When I was doing it, I was single, I was a full-time midwife, and because the acupuncture service became so popular, I had taken off the shift system. This was a massive privilege, and I think you heard Catherine say I was the only one in the UK to do a full-time midwife job as an acupuncturist, just dedicating my whole working week to acupuncture. And this really did open the door for me to be available for birth. I have to say it wasn't easy, because sometimes I'd be doing my antenatal acupuncture clinic all day long, treating conditions in pregnancy, and then my bleep would go at 5 o'clock, and one of my girls saying that she was in labour and could I be available to give her acupuncture for pain relief. So sometimes I'd be there all day and all night, which was quite challenging, but usually managed to see it through, and it was extremely rewarding. Now that's fine if you're footloose and fancy free. You also need to think about where you live in terms of where you're going to be providing this pain relief. Sometimes I had quite a long journey, and I remember one Friday night being booked to go down to St Ives in Cornwall, which is 2 hours drive away from the hospital, only to arrive on a Friday evening and being rather frustratingly handed my first gin and tonic by my friends, to get a phone call to say that somebody was in labour, and having to turn around without the gin and tonic and drive 2 hours back. I got to the hospital, I was wearing dungarees, and I walked into the room and she was in the second stage of labour already. So I had to drive back. So if you're going to provide acupuncture for labour, you really do need to consider how you're going to do it. Various people do it and do it successfully. I do know acupuncturists who manage it, but you need to think about your case and your other clients. If you've got an acupuncture clinic, then you have to think about cancelling your patients' appointments because you've been up all night doing a birth, or because you have to go and attend a birth. I have to say most of them are very understanding because they know it could be them. But as a practicality, it's important. So the acupuncture for childbirth teams have been set up in the UK. The first one was in Oxford, and a large group of acupuncturists got together, one of whom was a doctor who was happy to teach the team a little bit more about obstetrics, so that they were very well informed. And they got together and formed team work that worked on a rota basis, so that they would try and be available for their own patients in labour, but if the labour went on for a long time, or if they weren't available, then other members of the team could step in and provide the acupuncture for pain relief. And this has worked very well for them. It also opened doors for them to be able to work in the local maternity unit, which for them was the John Radcliffe Hospital, a very substantial unit in Oxford in the UK. And they did have honorary contracts to be able to go in to the hospital, which is fantastic for acupuncturists to be able to do that. Since then, further teams have sprung up. The Acupuncture for Childbirth team in London, and there are several others, which I do have a list of, but you can find them through the other websites. But they're in other parts of England, in Brighton, Hertfordshire, Berkshire, and several other places, York, the north of England, and they're springing up all over the place. Wonderful. So depending on where you are, you might want to consider setting up a similar type of service. So that's it from me. I hope this has been helpful. I hope I've encouraged you to get more involved with acupuncture and particularly acupressure for birth. And if you're attending births, I wish you very happy experiences. You may want a tissue in your pocket, because if you've never attended a birth before, it's one of the most moving and beautiful sights you will ever see. So be warned, it's a very emotional, fantastic experience. If you have queries or you're not quite sure, I don't mind being contacted by email. Here's my email address, and I wish you all the very best and happy birthing experiences. Thank you.
Well, thank you, Sarah. What a fantastic, informative webinar. You've been listening to part 3, Safely Using Acupuncture in the Final Stages of Pregnancy, Encouraging Labour, and Acupressure During Labour, What You Can Teach Your Patients, presented by Sarah Budd. This is our third part in our Acupuncture and Pregnancy webinars series, our first one being Safely Treating Conditions in the First Trimester of Pregnancy and Safely Treating Conditions in the Later Stages of Pregnancy. We also have an additional webinar for you that's Turning Breech Babies with Acupuncture and Moxibustion, presented by Bex Armstrong, Deborah Betts, Sarah Budd, and Ineke Vandenberg from Holland, an international panel of experts. My name's Kath Berry, and with Luke Rickards, we are Acupuncture Professional. Thank you for listening and have a good day.